Welcome everyone. I'm Sarah Dugan, Chief Executive of Worcestershire Health and Care Trust, for those of you that haven't met me. Welcome to this really important briefing for clinicians today. Everyone has been doing such a fantastic job working together in partnership during the COVID period, and actually it's really taught us a lot of lessons and shown us how well we can work together and how much we can achieve, to be honest, if we all have the same focus and we're committed to doing that. So really positive things have been happening during COVID, and I just want to say an enormous thank you to everybody on the line for everything you've done to support local people during this period. What we want to do today is give you an update on what's happening in the One Herefordshire programme of work and the work you've been doing during COVID, and really outline to you what the next steps are moving us towards the future. We've got quite a few speakers going to talk today, which I'll explain in a minute, but if I can just do some practical issues first. For those of you that joined a bit later, just so that you're aware, this session is being recorded. The session and the slides will be shared with you after this event, and we're hoping that you can then spread the word, share this with your teams and discuss it more widely. We've asked everyone except the presenters to keep their cameras off and everyone to stay on mute for now. Normal protocol applies given we're going to have over 100 people on the call. So if you've got questions, can you please add them to the chat box, and I'll make sure once we finish the presentation we cover as many of them as possible. We are quite tight on time, so I'm going to ask the presenters to pass on fairly quickly, but we are hoping we'll have at least 15 minutes for questions. If we don't have time to go through all the questions by the time we get to the finish time, then what we'll do is we will cut and paste those and we will send them out in a broader communication with the answer. So please be assured, if you feel your question hasn't been answered, we will come back to you later. It's perfectly fine to add questions to the chat while the presenters are speaking, but I suggest we don't stop in the presentation or we will lose our flow and our time scale. So if everyone can just note any questions while they think, and we'll come back to them at the end. We're scheduled for 45 minutes and we're aiming to finish on time, so I'd appreciate everyone's support with that. So without further ado, if I could just go on to the next slide, please. I'll just outline the agenda and who we've got speaking. So the agenda for today is Steve Vickers is going to talk to you about our approach to healthy communities. Jane is going to cover learning from COVID. Matthew is going to talk about a specific example with the community mental health transformation. We've then got Mike updating you around the Clinical Practitioner Forum. Ali will explain the work of the Transformation Group, and Connor will cover the Integrated Intelligence Cell. And then David at the end will come back to what does all this mean to you? What do you need to do and how do you connect with some of these conversations? We are going to move at quite a pace. I'll ask the speakers to hand directly onto each other, but I will be keeping an eye on time in case we start getting behind, and then I'll interrupt if required. So without further ado, I'd like to invite Steve. If you could take yourself off mute and we can start the presentation. Thank you.
I'm just slightly anxious that Steve hasn't joined us.
I know, I can't hear Steve. Are you there, Steve? Jane, are you happy to do this part and run into yours?
Yes, I think I can start off on this. I think I know the material pretty well. So apologies from Steve. He's obviously been unavoidably detained. So the first bit of the presentation really is a little bit about Herefordshire. Most of you know these things, but it's just a recap on what our system looks like, what our community looks like. We are relatively small in NHS and local authority terms, but that doesn't mean we're not a very complex system with lots of different players and lots of different and important services that we run. Next slide, please. A bit about our population. As we all know, it is very, very rural, and access times for our population are generally pretty long. This is access times for Herefordshire residents to their GP surgeries. And if they don't have a car, it's very difficult for them to access primary care, and even more difficult to access secondary care. Next slide, please. And our population is it's an ageing population. It's already old in comparison to the rest of the country, and it's certainly getting much older. The change that we're going to see in people aged over 85 is a very significant increase over the next 20 years or so. And so we do have to plan to manage the healthcare needs of a very changing population. Next slide, please. Again, this is the proportion of the population across Herefordshire by the different district areas who are aged over 65, where we were in 2001, broadly where we are now, and again, in 18 years' time, almost all of our population will be will be over 30% of our population will be over 65. So again, it's just a graphic to demonstrate that aging population. So again, next slide, please. But what we need to do is to help our population to stay healthy. And what makes us healthy? This is a slide from the council and from the Talk Communities programme that they are leading. And what we know is as little as 10% of our population health and well-being is really linked to accessing all of that healthcare that I've just been talking about. It's really very much linked to work and learning opportunities, financial security, affordable food, friends, families, communities, connections into communities. The super book I read not long ago called 10 Lessons for Living Longer and Better, which I recommend to anybody to read. And really it's those same messages. The things that keep us well and healthy and happy are generally not access to healthcare. They're the things that we can do for ourselves, and it's about how we keep our population and how we support them to help themselves in that way. So that was the end of Steve's slide. He would have done that last slide much more justice than I did.
Just joined, Jane.
And so, but I will move on. So my section of the presentation is this part, which is how we're really thinking about taking the lessons that we've learned during the last 6 months of COVID into designing the new NHS and care system in Herefordshire. So this slide is just an update of how we've done as a system in terms of managing the pandemic locally. And of course, you can't mention this without mentioning that we've lost around 120 people from COVID in Herefordshire in the last 6 months, with all of the terrible impact that will have had on their families and loved ones. But when we look at this data, we've managed really well. Generally, on the top right-hand slide, I won't go through all of the detail of this, but on the top right-hand slide, that's excess deaths. So the grey line is the last 5 years, the average deaths per week over the last 5 years. And generally what we find is that that the deaths that we've had, the excess deaths over the averages, have all been related to COVID. So our other systems have worked really well. And in terms of patients who needed to be admitted to hospital, our outcomes were better. And some of that we had more time to prepare. It hit us a little later than others, but our outcomes and mortality for those admitted to hospital were better than the national benchmarks. So first of all, that's a huge well done to everybody who's been involved in all of the clinical teams, but it's not just those teams in isolation. It's how they've worked together. It's the way that we've worked as a much more integrated system, I believe, as to why we've so far got some better outcomes than the benchmarks nationally. Next slide, Ali. So where we are at the moment in terms of NHS planning is we're in phase 3 of this pandemic, which is about planning for recovery. And obviously all of us here are really busy at the moment, both planning and delivering the recovery of services and activity. And again, we're doing really well on that. And we're also preparing for winter, a huge amount of work that's started on that, and we'll inform you about that as over the next few weeks about how we have planned for winter. But the third thing that we're doing is planning for phase 4. And what phase 4 is what's been called in NHS planning terms, the NHS reset. So what does the NHS look like from April next year? How do we make sure that the lessons that we've learnt over this last 6 months, most of which has been incredibly positive, how do we take those lessons forward and really put it into the way that we're going to work in the future? So next slide, please. So what are those lessons? What have we learnt? And we've formally spoken to many people and pulled together everyone's views on what have we learnt over the last 6 months. And I think it probably summarises into these bullet points. We've seen new leadership, a new leadership style, and we've certainly seen many new leaders emerge across our system, working across the system and not in a siloed way. And most of those have been our clinical leaders. We've worked in a very agile way. We've made rapid decisions, and a lot of that has been facilitated by this type of technology. We've had proportionate governance. So although we've had governance systems making sure that we're safe in the decisions that we're making, it's been at a proportionate level. And of course, removing all of those usual financial arrangements facilitated that as well. And what really came out was the importance of place. What we've done is we've taken the national directions and guidance, but we've delivered it all pretty much in Herefordshire, with the people and the clinical and other practitioner leaders across Herefordshire working together. So how can we build this then into a new way of working to deliver phase 3 and prepare for phase 4? So the reset of how the NHS works, and more importantly, how the NHS and care works together. Next slide, please. So this slide is a bit busy, and there's quite a lot of detail that's coming later on in the presentation. So I'll try. I'll not spend too much time on it. But the important thing really here is that whilst this looks busy and it looks really complicated, what it's replacing is something that was much more complicated and much more heavy on senior leaders' time. And so what we've designed using the learning we've had so far is that we've dispensed with an awful lot, a large number of meetings and governance processes that too often didn't really add enough value for the time that they were taking. And we've replaced it with 4 key forums. So on the right-hand side of this slide is the Clinical Practitioner Forum, which really is the engine of how clinical leadership will be absolutely hardwired into the way that we're going to manage and the way that we're going to lead our system in the future. Mike Hearn chairs that, and he's going to give some more detail about that a little bit later on. And that forum is supported by 2 groups, a transformation group, which is really the project and programme managers who work across all of our systems, coming together to work together. Ali Bolton leads that, and we'll talk a little bit about that. And then an intelligence cell, making sure that we've got the data and the information that we need to make the right decisions, and Connor Price leads that, and we'll talk about that later. So that's really the engine room of it all. And then on the left-hand side is the transition board. So again, this is where we've replaced an awful lot of meetings with a single board. I'm currently chairing that, and it's a board of the senior leaders from the local authority, from mental health, from primary care, from the CCG, and from Wye Valley representing acute and community services, where we come together on a weekly basis to make sure that we maintain momentum in the way that we do the right things and we do them quickly. So its purpose really is to support the Clinical Practitioner Forum to deliver improved services and redesign pathways to better support our population. and also we have a role in planning the phase 4 system reset. At the left-hand bottom of this slide is the principles, the things that we've agreed are our values and the way that we're going to work together. So transition board is there in place, meets weekly, so we're able to be as agile as we can with the making hopefully will be the right decisions. Next slide, please. And what the transition board has done has it's agreed 7 system transition priorities. So these are the project areas where we've agreed with the Clinical Practitioner Forum that these are the things that we should really concentrate on over the next 6 months, that we can make a real difference to both the our population health and outcomes and the sustainability, so how we make best use of the resources that we've got. So I'm not going to go through the detail of these. They're there for information. There is quite a lot of information that's available about these, and we can certainly send all of that out. But at the moment, it's probably helpful to concentrate on one of those and just give a flavour of the sort of work that will be done and how that will be taken forward. I guess the other important thing to say just before handing over is, as we've selected the priorities, these are resource backed. So we have project management resources and other organisation resources that are have been put in place to make sure that we can drive these priorities forward. Okay, so I'm going to hand over to Matthew Hall to talk about the Community Mental Health Transformation Project.
Thank you, Jane. Hello, everybody. I'm Matthew Hall. I'm Chief Operating Officer of Worcestershire Health and Care Trust, and we provide the NHS mental health services in Herefordshire. One challenge that's faced GPs across England has been that as mental health services developed over the past 20 years, a lot of the emphasis has been put on very specialist mental health services. And that's created a divide between primary care and mental health statutory services. What that typically means is that although, if somebody's in a mental health crisis, or they need admission, or they've got schizophrenia, or they require an IAP service, that there's a service for them. But there's a large group of people who are just seeing their GP for mental health support. They've got unmet needs and they don't meet traditional mental health criteria, and they tend to fall between the stools, which is very frustrating for everybody involved. Part of the long-term plan mental health investment standard funding is to implement a new solution which creates new community mental health teams that remove the barriers between primary and secondary care. So this is new money to be invested into a new model of care, additional mental health workers, and more money for the voluntary sector as well, to provide support wrapped around PCNs. The NHS in England launched some pilot sites last year. So there were 12 pilot sites going on across England looking at this new PCN-based mental health model. Within Herefordshire and Worcestershire STP, we were successful in winning funding for a pilot site. So we had to select 50% of our population to be covered by the pilot. So in order to make it contiguous and also to test the rurality model, we selected the entire population of Herefordshire and the western part of Worcestershire as well. So between January this year and now, we've been preparing for and setting up new teams of mental health workers around PCNs. So core principles of the model. Next slide, please. So core principles of the model are we want to offer a seamless service without artificial criteria barriers. So no more of the GP trying to guess the team or the pathway that the patient needs to go down. But it's also a model that's a quid pro quo as well. So the whole emphasis around this is partnership working with GPs and locality nursing teams rather than handing off between teams. So one of the principles of the model is that there's no referral and there's no discharge either. So just as patients remain with their GP long term. When they need mental health input, the GP can hand them on to their locality team, and at the point where they've finished active care, they're not discharged, they're just inactive on that caseload for a time. We've got a list of criteria, outcomes and success outcomes that are going to be monitored as well, and we've just received those this week. So there's outcome experience measures that are going to be monitored as well. So next slide, please. So in the new model, this just describes the patient journey through to getting a mental health service. So when the person goes and sees their GP, they will agree with their GP that they have a mental health need. It doesn't have to be a well-defined mental health need, it just needs to be broadly a mental health need. And the decision point that they're going to receive a mental health service is made then and there. The GP will then book an appointment slot through Choose and Book with their local mental health worker, and the local mental health worker will see and assess them within a month and agree a plan, and either take them onto caseload, move them on to specialist support, advice and intervention. So some of the specialist mental health teams may get involved at that point. So if somebody's got an eating disorder, or if they're a young person who's developing psychosis, or if they're going to mental health crisis, they may move to the right of the diagram. Or they can link them up as well to voluntary sector services. So, you know, things around community resilience, personal well-being. So part of the model is that we're working very much with the voluntary services as well. And when the person has no longer got an active mental health need, you know, we'll agree that for that time we'll be stopping seeing them. They can either go back to their GP or recontact the mental health team at that point if they need additional support. So if we move on to the next slide. So a little bit more of a kind of representation of how we see the model working, really. So it's a model that works, you know, very closely with GP, PCN locality teams, but also links to the specialist mental health services that we've got across Herefordshire, and also the voluntary services as well. We're aiming to ensure that people's physical and mental health care needs are met together. So obviously we'll have and maintain strong links with the PCN locality teams. So our current position at the moment, and I think there might be another slide. Yeah, that's right. We had to pause the programme in March because of COVID, so we would have had this model up and running from April, but we've reinstated it now with a planned go live date of 1st of October. So all PCNs continue to be represented in the model development, and we'll undoubtedly continue to refine practice as we learn, and our influence through what we learn as we roll out the model, and through the Clinical and Practitioner Forum as well. And we're just starting our first 2 test and learn sites as well. So from next week, we're actually working with one of the PCNs in Hereford to just have a couple of weeks before we go live with the full model to just test some of the concepts and check everything works properly. And we'll continue to report our progress through the transition board. So, Mike.
Thanks, Matthew. So I'm Mike Hearn. I'm assuming I've been around a while, so I'll probably know most of you, but I'm a local GP, but also managing director for Taurus Healthcare, so the GP Federation that works with the clinical directors and supports all their work across general practice in particular. So the CPF, or Clinical Practitioner Forum, I guess is important to really highlight the change of ethos, really, the change of thinking that's been considered behind some of this. And I think this is really bringing in all the things that Jane was talking earlier about the key elements of working from COVID, where clinical and frontline practitioners have played such a key role and been involved from the word go, and have often have led very much the response to COVID. And we wanted to build on this, and the CPF is a key part of that. In terms of why is it called that? Well, the Clinical Practitioner Forum, clearly we always talk about clinicians with regards to often these clinical forums, but the practitioner element was to try and ensure that we quite clearly wanted to involve social care and communities, and I think that's also it's important to highlight. So really, this is a forum which is going to coordinate the kind of that clinical and practitioner voice, and the key things really are listed there. The key functions that it's designed to do. The first one, obviously, is that those system priorities, and there will be local agendas. There's the national ones inevitably that come through, and obviously sometimes we can all look at too many priorities. So it's how do we ensure that we deliver on some of these things. And the particular thing with some of the approach here is how do you involve those frontline leaders at the word go, at the beginning of the project, early on in the scope, rather than traditionally when we've often done it further down the line. So I think that's one of the key differences here, and the Transition Board and CPF are working as one, and you'll see, I think, hopefully that will become more and more apparent throughout discussions. So there's the big stuff, but there's also the niggles. So we've recognised during COVID that the day-to-day stuff that goes on that makes such a difference on the front line can easily be sorted sometimes. And actually having those conversations at the CPF, if indeed they need to be, then that's a place they can be escalated to. Although, of course, we'd always encourage everyone to pick up the phone and speak to the people that they're working with, and try and create that sense of team wherever you're working, whether that be in the community, at a PCN level, or indeed across the county. So I think that's what we'd like to ensure, that the culture moves towards that one Herefordshire feeling. Clearly, the CPF is also there to look at developing the learning, and we can coordinate that and linking that with the education. So often we look at educational events like this one, in the future, how do we link in that priority of when we think about COVID, clearly everything was connected. But if we think about the waiting list issues that may be occurring, if we think about the access to mental health, as Matthew was saying, or indeed access to social care, we all come across those problems day to day, and actually what we need is a forum where we can bring some of that together. I'm going to leave David Mowbray to talk through the actual membership shortly. So I'm just going to go on to what that really changes for us. If I could have the next slide, please. So I guess these are just some examples of what it might change for people listening today about where we may have considered traditionally that we would have escalated things in different ways. And what we're hoping really is that this is a forum where we can promote that communication and promote that positive engagement across providers, so that actually we're increasingly working for our population, we're working as a team, and rather than working for an organisation. So there are specifics there of examples where there may often be concerns that something's been initiated, I should say, without involvement between primary and secondary care. And of course, what we're hoping is rather than that done in silos, that is brought together. We look at the scopes together, and already we're seeing that what may be considered traditionally a medical model, we have to consider what is the mental health element of people on that waiting list. What is the opportunity of working with Talk Community and wider voluntary in terms of bringing in other ways of working? So again, that's been very positive, some of the discussions and opening that early on. If you've got ideas, clearly what we want to encourage is, rather than necessarily this goes through the formal bodies that we had before, is let's get them in, let's get them working, and actually let's get you all involved in this, because this isn't about a meeting which is kind of a million miles away from what you're doing. It should be a meeting where you feel you are able to at least contribute towards in whatever form that you wish, given the capacity and time that we are all struggling with currently. Loss of discontent sometimes can exist when things don't go well. And actually how we address those, I think, is really important for us to do in a constructive way. And I think that's what I would encourage people to look at. So yes, we can report them, we can go through, we can escalate them as concerns through the traditional bodies, or actually we could be thinking differently now moving forward. And actually, how do we kind of perhaps know our representative of going to different meetings if you can't get there yourself? And actually, how do we ensure that they know what's going on and also can bring some of those things up, and so we can have those challenging discussions, because there will be at times need to be challenging discussions, but how we cooperate on this is going to be really key. And likewise with some of the contractual things that may sit there, and traditionally where we would have considered whose responsibility it is. What we're hoping now is that we'll be thinking of that as a one Herefordshire pot, and actually what we need to be clear on is how do we move the resource so that it best suits our population's needs. So I hope that gives you a summary of what the CPF's about, and I would certainly ask you to engage all your kind of relevant participants in there, and please kind of feel free to comment on this as we move forward. Thank you. So I'm going to move it on to Ali, who's going to tell you about the transformation stuff. Thank you.
Thanks, Mike. I too have been around a long time, so probably know lots of you. But for those of you that don't, I'm Ali Bolton, Associate Director of Improvement based at Wye Valley, and I have the pleasure of leading the transformation group. You've heard Jane and Mike talk about the support functions that the transformation group and the intelligence cell provide to both CPF and the transition board. The members of this group are all engaged in delivering programmes and projects across Herefordshire, and are already working across boundaries. These guys have been probably quietly in the background doing that for years. What we've done is expose that almost. So yes, they're encouraged to work across boundaries, indeed expected to work across boundaries. And through joining forces in this way, we have absolutely increased and made the most of our capacity. This is quite a precious resource, and our ability to deliver value to the system is absolutely increasing. Now, the membership of this group, as you can see on the screen, is multiple and varied. So we've got transformation, improvement, programme and project bodies in there, but also a big part of our team are the digital and technology and educational partners in amongst that. On screen, there's also a list of all the organisations that are a part of the group. And you can see at the bottom there, we've got the voluntary section care homes aren't yet involved, but we are working with them to find those people that could engage with us. So if you'd like to know who the members of your organisation are that are a part of this group, please do feel free to drop me a line. Equally, if you'd like to be a part of the group, drop me a line. And leadership of this group. These guys are all real self-starters. They're all motivated and keen to deliver. They're an absolute pleasure to lead, and I genuinely do mean that. They are utterly brilliant at joining dots in the background and making sense of the complexity that we're working in, and they really do smooth the way. And from a leadership perspective, they make my life very, very straightforward. And the governance of this group, this is an odd one. The group it's not a formal structure. And the members of the group remain kind of responsible and accountable to their own organisations. The difference being they report their progress through to Transition Board and to CPF for oversight. The group does, though, provide space for these guys to work together. And to consider anything new coming through CPF alongside their current projects, but we are also open to reviewing anything that's coming through to us from the national and regional environments. Yeah, whistle stop tour, but that's the transformation group, and I will now hand you over to Connor to talk about the intelligence cell.
Thank you, Annie. So yeah, for those of you who don't know me, I'm Connor Price, so I'm leading on the intelligence cell at the moment. So on screen, you should see our roles and goals of the intelligence cell. So It's made up of head of informations and associate directors and lead analysts from across CCG, Taurus Healthcare on behalf of General Practice, Wye Valley Trust, Herefordshire Council, Public Health England, Worcester Health and Care Trust, CSU, St Michael's Hospice, West Midlands Ambulance Service. So as you can see, we've also got quite a broad range of involvement and key partners that really want to work together and build the relationships between each other. So it's an integrated approach that looks to maximise the data usage for system improvement. We're looking to seek one version of the truth. I mean, a lot of the confusion that we get at the moment is that different organisations, different people will view different sets of data and it will tell you different things. And obviously the problem you get then is that confusion or dismay of one person seeing one thing and someone else seeing something else. So what we're trying to do is pull that together really and really work towards that single version of the truth. For Herefordshire, it will highlight health and social care escalations and provide oversight of the system and the transformation that we're doing with it. So that is by mapping progress and projects and objectives and outcomes. We meet fortnightly and act as an enabler, obviously, to the Transition Board Clinical Practitioner Leadership Forum and the Transformation Group. So we're heavily involved with those forums and present there to make sure that we're part of the discussion so that we have a better understanding of what data is required. And that's usually an important bit of we tend to get the request and not necessarily know what it's about. So this is that two-way conversation of the forward and back of what's needed and what's actually required. And so to utilise this group, there is a process by which a project or programme of work is approved by the Transition Board or the CPF, and then we can look at dedicating the time to pull that data set together. Obviously, it just allows that capacity management, so that's hence the improvement of it, but it also then means we can really dedicate the time to the things that are really needed as well. Yeah, I mean, it is a whistle-stop tour. We have got information available. If you do want to contact me, I can let you know more detail of it. But yeah, so I'll hand you over to David to go through how to get involved.
Hi, David Mowbray. I'm Obs and Gynae consultant here in Hereford and its medical director. Thanks a lot, Connor. Just emphasise what Mike has said about the Clinical and Practitioner Forum, which is the way that colleagues need to try and get involved with all this collaborative working. And this is really for everybody, for pharmacists, social care practitioners, physiotherapists, OTs, nurses, mental health workers, as well as doctors and nurses. The CPF meets virtually every Tuesday at 4:30 to 5:30. It's chaired by Mike, so it's very accessible. It's got senior representation from all areas of the caring bodies in Herefordshire, so secondary care, the council, mental health, and ourselves, and primary care. So if you consider you've got a problem that you've identified or an idea for improvement that crosses organisational boundaries, and there's quite a lot of those, so it's not just in the traditional silos. If you've got a problem or an idea, then it's the ideal forum to which to bring it, and to which to make sure that it truly succeeds or has the best chance of succeeding. You raise it with your appropriate representatives, so it's either myself in Wye Valley, the other associate medical directors, Mike and Lauren in primary care, Barney and John from mental health, Amy Pitt in adult social care, and Ian from the CCG. We will then discuss it, and if it's thought to have potential, if it's thought to be a goer, we'll ask you, with perhaps the support of the Ali's team, to do a very short scoping document, because we're very keen on keeping this paper light and agile. A short scoping document, and then if it's thought to be successful, have potential, you will then recruit the support, the transformation and the information cell, which has a good chance of making your idea real. So the real plea is just to get involved. And I'll leave it at that, I think.
Thank you very much, David, and thank you to all of our speakers. We haven't got a huge amount of time, so I'm just going to suggest what we do next is, I think we had a little technical blip in that some people's diary invite moved to 2 o'clock, strangely. So Stephen Vickers wasn't able to present his session at the beginning, so I'm just going to ask Stephen if he would like to add anything. And then I'll pick up the general questions about representation with David and Mike that were in the chat. I think they've partly been answered. And then I'll ask Matthew to comment on the mental health questions, of which there are quite a few. So it may be that we do a briefing sheet on those questions on the mental health project and get that circulated as well when the slides are shared later. So if I could just ask Stephen if he'd like to add anything first.
Yeah, thank you. And again, sorry for being slightly late, but I think what's been presented, I'll just add this, it's only a minute, but what's been presented is obviously a new way of working. And importantly, and I think excitingly, I hope people will have picked up a new narrative about the way that we're working, both together and with our communities. And I think what we do know is that the demand is simply going to outstrip our resources and our ambition to support populations if we continue to run the same race. And so thinking differently and doing things differently becomes critical, of course. So yes, absolutely, we need to continue to provide high quality health and social care services, which you're all out there doing on a daily basis. But we definitely need a fresh perspective on this. And I think that's where the Talk Community programme really comes into its own. And you will have heard Talk Community mentioned more than a couple of times here, which is exciting in of itself. So Jane mentioned, I just came in at that point, that the research shows that 10% of the population's health and well-being is linked to accessing the services that we provide, but most of it isn't. And to state the obvious, therefore, the best way that we can support our residents is to connect them and make sure that they're preventing from needing our services. But importantly for me, even when they do need our services, I think it's also important for us to realise that community support remains as important to our patients, our service users. So it doesn't stop just because they come into our services. And so just finally, I would say this, that Talk Community isn't theoretical. It's working, it's out there. We've been doing this for 3 years. And my ask really is that we continue to build on that success and embrace it into all of our practices. And I'll stop there.
Thank you, Stephen. Can I just ask David or Mike to comment on the question about nursing and AHP representation? I think you talked, David, about anybody could approach the clinical forum with a query. I guess the question might also be about representation on the groups. So I don't know if you want to comment any further on that.
Well, we have nursing representation from both Nikki and Lucy at Wye Valley. We don't have AHP as far, but I'm certainly not averse. Obviously not to having colleagues partake. There's always an open invitation to anyone who wants to come along and bring an idea in any case. As for permanent membership, it was the combination of not making it massive and not taking up too many people's time. But if we could certainly look at broadening it. Absolutely.
Yeah, and I'd just add to that.
Yes,
sorry, Mike. Just to add to that was the evolving nature of this. So this wasn't a starting with terms of reference and with the purpose of the meeting, and it was really key to engage. So if there are people out there that need to be engaged, then absolutely that's the purpose of the forum, and the flexibilities exist around that. Sorry.
Thank you, and thank you, Andy Watts, for your comments about the approach from leaders within the community. I think there's a fundamental principle of this whole conversation, isn't there, around a commitment from all of the leaders in the system to work together, to work differently, to really innovate and focus on our population. And I guess what we're trying to do here in this new approach is put some structure around that to enable that to happen in an easier way, in a more agile way, and support all of our clinicians. I think all involvement and suggestions are welcome, is what I hear. And what you can also see is that all leaders in the system are very open to any approach about barriers to making some of these things happen together, and actually look to how we can constantly remove those barriers. Can I just go on to Matthew then? There was quite a few questions about mental health, Matthew. I don't know if you can answer some of them quickly, and then maybe we can do a briefing in a bit more detail to follow.
Yeah, I'll keep answering till you stop me then. Okay, so the first one from Crispin Fish was about what about care navigation straight to a mental health worker? So care navigator picking up the referral and passing it straight on. I guess what I'd say is part of the kind of the underpinnings of this model is that we're working together with primary care. So this is part of a primary care extended team. What we want initially is for people to see their GPs before the mental health services are involved, because we want to make sure they've had a proper kind of discussion about all of their needs really, and that we've ruled out any physical health problems that may be impacting their mental health. But having said that, you know, this is a pilot, and it may be that as we go on through the pilot, we find out that yes, okay, that is actually a valid pathway. But because we're doing a pilot, we have to start with a kind of set of rules about how the thing's going to work at the beginning. So initially, it is going to be person books an appointment with their GP. They have a discussion. If the GP identifies a mental health need, they'll book an appointment through Choose and Book. Nigel Fraser's asking how crisis needs are met. Well, the crisis services are still there. In April, we set up a new way of accessing mental health crisis services. So we've got a 24-hour, 7-day-a-week crisis line now. It's a single telephone number. Members of the public, people who've got no mental health problems, people who haven't got known mental health problems can ring that number. They can speak to a mental health professional, and if they need to access a service, actually they can access it that way as well. So within a month, alarmingly slow from Crispin. I think that's a long time to wait if you're in great need. But I think back to my previous point about crisis services, they're still there, they're still available. If you're in immediate crisis, you'll get seen the next day. If you're in slightly lesser crisis, you'll be seen within a few days. And part of working closely with PCNs anyway should be to have that negotiation about somebody's urgency of needs and agree between the team and the GP how quickly they need to be seen. So just going down, will CAM services be involved in this? Well, no. So question from Fiona Goodwin there. No, it's only working age adults and older adults for now, and not learning disability services either. So for CAM services and for learning disability services, referral pathways stay the same. This is just for people aged 18 and above. And I think that's it for the...
Just one about pre-existing. There's a couple of other things, Matthew. I don't want to dominate with mental health questions, but we'll just complete these quickly. There's a question from Verity around how the pre-existing mental health nurses in primary care fit into the new model.
Okay, so we've undertaken different negotiations with different PCNs about how we're joining services together. So certainly in some PCNs, we have agreed how if they employ primary care mental health workers within their practice, how they'll work together with the teams. And that's different from PCN to PCN. We also employ as an organisation some primary care workers, and they're being incorporated into the model as well.
Thank you. I'm going to come on to Jane in a second because I know she wants to add another comment, but the other comment that was embedded in the mental health questions further up was around the importance of integrated care records. So just to say for everybody's information really that the STP digital work stream is really moving forward at a pace, and the number one priority they've agreed in that work stream is to ensure that we have that integrated care record. I know lots of work has been done in Herefordshire already, but actually it is the vision across the STP to really expand and enhance that moving forward. So there's a lot of work. What I suggest we do, because there's quite a lot of comments on the mental health project, is I'm more than happy to set up a separate WebEx on the mental health project if people want to engage in that conversation and learn a bit more, rather than us take over the whole of this session, if that's okay. If there's an interest in that, if you could put it in the chat, I'm more than happy to make sure we set that up. Jane, you wanted to come in?
Yeah, it was just to, and I'm aware we're sort of slightly over time, but I just wanted to pick up Andy Watt's comment about that he doesn't think COVID can take all of the credit, and thanks Andy for that. I think you're absolutely right. I think in Herefordshire we started from a good place. I think we'd built some relationships of trust between organisations already, and I think we were already in a good place. So we were well set to really use this as a springboard to make things happen much more rapidly than we would have otherwise, and to really accelerate the change that we all wanted to see. So thanks for that comment. And I guess my last comment is this is an evolving situation. I don't think any of us believe that what we put in place now is going to be the final thing. This is a transitional arrangement, but I do hope it's the basis of the way that we're going to work in future, and we are going to work in this much more integrated way that allows resources to flow to where the patients most need them, and we can do that in a way that's less transactional than we have in the past. So I think we've got the makings of a really fantastic system, and I think we've got just great foundations to build on.
Thank you. It's hard to say any more to sum up than Jane's already said, because that exactly captures what this conversation's about, and it is about development, next steps, working together and finding better and better ways to improve the health of our population. So we're really grateful you've all joined. I'm conscious we've come to the end of our time. If any of you've got suggestions or areas we've talked about you'd like to know more about, or you'd like to know more about specific groups and membership, if you could contact any of the people who've been talking today, because this group will coordinate the response and the next steps. So if you forward to any of the group members any further thoughts you have, that would be really, really helpful. So can I just conclude by thanking you very much for joining the call today. It's great to see so many local clinical leaders on the call. Actually, it's up to all of us. It's up to us to make this happen and us to make the difference. So thank you for joining. If you've got any further questions or suggestions or ideas, please keep them coming and keep feeding them in. Thank you all very much.